You're watching CTOM TV. Knowledge is power.
So I'm ER positive, diagnosed with IDC, it's invasive ductal carcinoma for everybody else.
Yeah.
Lumpectomy done in July 2018. All node and tumor clear margins. Their chemo dose dense for AC and D and
Okay.
4 Taxol every 2 weeks.
Okay.
I also had Neulasta injections the third day after infusion, radiation on and 16 plus 4 boosters.
Yeah.
I was on anastrozole as of July 2019.
Okay.
And February this year, I noticed an awful lot of pain in my S1 vertebrae, and I usually go chiropractor. Anyway, long story short, they discovered my nagging, the doctors, they tried physio, chiropractic, nothing worked. I kept nagging. They did a CT scan, and hence they found, what do they call it? Indicators of cancer after the CTA scan, nuclear scan in the S1 vertebrae and the right of the sternum.
Okay.
And
so
stage 2, grade 3, now metastatic.
Okay. So just a quick thing. Now you're one of, I mean, a lot of women don't get chemotherapy. So you had the standard chemotherapy. You had what's called doxorubicin, I believe, and cyclophosphamide. There is a new protocol that came out that shows that you can greatly reduce the risk of heart attack by taking basic heart medications called ramipril and bispropol. These are what are given to people with heart conditions. So while you're on the chemotherapy, I know it's a little too late for you right now because you've already done this chemo, but I want every woman out there to know that they can actually take these 2 drugs, ramipril and bisoprolol, the 2 different classes of drugs to prevent heart damage.
Okay.
Significantly. So data is relatively new. It just came out literally the study just came out a couple of days ago. So I want all women to know that if you're getting chemotherapy for breast cancer, make sure you are taking something to prevent any further heart damage, just in case.
Sorry, I just wanted to say at this point, they want stereotactic radiation. I'm in a study.
Okay.
They're going to do 5 zaps to those spots.
Okay.
Pacla, the Faslodex and the Ebrance, there's easier to say on. And I had a stroke from...
I'm sorry, you're cutting out. You cut out for the last part. Yeah, I can't hear you.
You can't hear us either?
I can hear you.
Something happened with your connection, Joanne. Oh, there you go. No worries, I can hear you. So we only heard the first part where you were saying you had a stroke. What did you say after that?
The neurologist thinks that it was from the chemotherapy, and they said, even though it was a year later, I assumed, anyway, it done is done. I'm pretty good. I'm fine. It was a mild stroke affecting my speech, but anyway, carrying forward, I want to make sure that what I'm given now is going to be proper, because I'm kind of feeling untrusting of the work that the doctor, the oncologist, because I asked her about, we did a lot of studying, and I asked her about blood biopsy. Do that here. We don't do that here at Juravinski. So
So sorry. Have you been given a bone modifying agent, a bisphosphonate?
I don't think so.
Okay, you should be on Zometa. You should have been on Zometa from day 1. You can get that prescribed from your GP if you want. It's a injection once every 3 months, and it significantly reduces the effects of not only does it reduce bone metastasis, but it also reduces the growth of the cancer. So it's the only, there's many different, it's a class of drugs called a bisphosphonate. There are many different bisphosphonate drugs available. They're made for osteoporosis. But this particular one, Zometa, is able to not only slow down the growth of estrogen-positive breast cancer significantly, it also prevents bone metastasis and resolves metastasis should you have it.
Thank you very much.
Zometa. Now, have you been prescribed? You've been prescribed Ibrance and Faslodex?
Yeah. Yes.
Okay.
Yes.
So we don't know. Okay. So that's
injections yesterday.
okay. So that's a good combination. The problem is we don't know. So Ibrance is palbociclib. That's the first generation CDK4/6 inhibitor. We don't know if you have mutations in your DNA that will prevent that from working. So what I would tell your doctor is you want to go straight, you either get tumor DNA sequencing or you go straight to abemaciclib.
Can you spell that? Or
Yes,
can one of the girls?
it's in the document, abemaciclib.
Okay.
So forget Ibrance, go to abemaciclib. Now, Ibrance may be good enough for you, but without the genetic testing, we don't know.
Okay.
So don't risk it. Take the best CDK4/6 inhibitor, the one that works against many pathways and against many different mutations, and that's abemaciclib, and also get Zometa for your bone metastasis. Now, the radiation will be quite effective too, and that should really help you, but you should be on Zometa. One of the reasons that some doctors don't prescribe Zometa for everyone, and many doctors do, we use it on everyone with cancer. One of the reasons is there's a bit of misinformation on Zometa. Some doctors will say, oh, it causes osteonecrosis of the jaw. The studies showed what osteonecrosis of the jaw is: weakening of the jawbone. The studies actually show that it only happens in about 0.5% of patients, and those patients had really bad teeth to begin with. So if you need a lot of dental work before you get the drug, then get that dental work done just to be on the safe side. But really,
this is perfect.
yeah, so 0.5% is ridiculously low. So a lot of doctors are misinformed on how big the risk is. It's really low. And you can find the risk just by Googling it. You can say risk of osteonecrosis with Zometa, and it will tell you right there. It's really not a big risk.
Okay, so can I just?
Thank you very much.
You're welcome, Joanne. That's what this is about, is for you to be able to ask questions specific to you, get some information about what's possible, and hopefully, as in your case, things that you can just pick up the phone, call your doctor about, get a prescription and go.
And be demanding.
Yeah,
this is your life.
Be squeaky. That's that you just, and always remember, that's what me and my team here are here for, is to help you either learn the language and the questions to ask so you can advocate, or to do that advocacy for you. And of course, Alex and his team on the research side can coordinate the genetic testing and make sure that your doctor gets the proper information they need to prescribe the right treatment.
Right. So once again, as a summary, everyone on cancer should get a bone modifying agent. There's the two that are the best ones. One of them is called denosumab, and the other is a bisphosphonate called Zometa. And if you do not have any genetic testing and you're being offered a CDK4/6 inhibitor, if you don't have any genetic testing, if you do have genetic testing, then we can look it over and say, yes, palbociclib will be fine. Yes, ribociclib will be fine. But if you don't have genetic testing, then just go straight for the best one, which is abemaciclib.
I think I did have genetic testing. They sent it down to California for Oncotype DX.
That's
cancer node negative.
That's not genetic testing. What that is prognostic testing to see if chemotherapy is a benefit to you. We discussed that in the beginning of the
Okay. I'm sorry.
Oh, no worries, Joanne. You know, right now in the world, there are 7,000 different types of genetic tests. And then there's there's this whole lexicon of language that is associated with all the different types of treatments and genes and all the stuff. So it's really complicated and it's hard to tell what's what. And a lot of oncologists, because there's just so many new tests, so many new treatments, they don't necessarily know themselves what is and isn't genetic testing and all the assessments. So no need to apologize for not knowing this stuff. There's a lot to it. The most important thing is that you just keep asking questions.
Yes.
Thank you.
Yes.
Thank you very much.
Thank you for watching CTOM TV. Subscribe below and stay informed.